this thing called managed care. And what it did was it took all those costs on the far left side of that graph, which were really high. And I'll tell you, I worked in a hospital back then, a psychiatric hospital for kids. I worked there right after undergrad. And our treatment plan for your child began by looking at what your benefit was for how many days they could stay in our hospital. If they could stay a year, we kept you a year. If you could stay 2 years, we kept you 2 years. If it was unlimited benefit, we kept you until somebody broke you out of there. And we were trying to figure out how we could possibly help get you better in 3 months. And I'll tell you, this was very well intended by the people on the units. And what the idea was you were so messed up, and this is so complicated, that really we needed to be with you your entire lives. And if we could stay with you your entire lives, you were going to be fine, but otherwise it was not going to work out. And that was truly the premise for how psychiatry was practiced back then. So guess what? Insurance companies decided that's really a bad way to organize a delivery system, because there's no accountability for outcomes, there's no accountability for anything else. So we are the blue line there, y'all. So when managed care came in and took spending down, look what it did to us in the mid-90s. And while we got back up to levels kind of sort of after that, that jagged thing right there put us on a trajectory on mental health that kept us being managed as a cost center for the next 20 years. And this slide, by the way, is also to show you that I have a lot of numbers. But what it shows, if you look at what mental health spending was in 1986, it was just under 10% of all healthcare spending. In the early 90s, it was down to 8.2. By 1996, it was down to 7.4%, and it hasn't really changed since then. Now you can say, well, yeah, it only went, but the mental health people I know say, well, it only went from 9.3 to 7.4. Are those numbers fairly close, Andy? And I'm like, no, that is a huge percentage of 9.3 that we no longer have. That's called our margin for innovation and making things work. That is gone. So we have basically been having the same mix of care, outpatient psychotherapy, medication, and hospital care, managed and doled out to y'all since then. And I promise you, every one of your healthcare providers, your insurers, is still providing you care that way because they have to. They want to innovate, they want to do some different things, but you are all managing them as a cost center currently. And if any of them went to you and said, by the way, I'd like to, how much is, somebody really fast, y'all are finance people, how much would you have to increase your PMPM to go from 7.4 to 9.3? 25%, 20-ish, let's say 20%. If they went and said, we got to increase your PMPM for your mental health care by 20%, y'all will go to a different vendor for good reason. So this is why we're in a bad situation, because we're a cost center, and you don't want to be a cost center. So I'm going to argue that that's a bad idea for business. And one reason I'm going to argue about that makes actually these arguments a lot easier now than they used to be, is because we all went through this little pandemic thing. And this little pandemic thing has reminded us all that we actually have feelings, and we actually need to have other humans around us, and we actually can get scared, and we can actually get depressed. Today, right now across America, rates of depression and rates of anxiety, and these are clinically elevated levels, so it would be at least mild, we don't know how much you're mild and how much you're serious, are 340% of baseline. 3.4 times as many people today, about 22% of people, report clinically elevated symptoms of depression, and about the same percentage above baseline of people with anxiety reported. So when people argue about why aren't we back to full employment yet, is it the extra unemployment benefits that we're giving people? Well, maybe, I don't know, I'm not that kind of economist, or I'm not an economist. But it may also be the fact that 1 out of 5 people are still depressed. 1 out of 5 people are still significantly more anxious about a variety of things. And we're seeing that most elevated among our youth and young people. Rates of pediatric emergency room visits for suicide are double pre-pandemic levels. The rate of suicide did not go up last year overall. It went down for people my age. It went up for Black adolescents and Black young adults. And it stayed at historic rates that it had hit in 2019. 2019 was the high point for suicide in America. We've stayed at that level. For people in their teens, 20s, and 30s, it's the second leading cause of death. By the time you get to your 40s, it's the third leading cause of death, and it's the fourth leading cause of death for during your working age years. So these are pretty serious things, and we're doing a horrible job. We were doing a horrible job pre-pandemic, and we're doing a horrible job now, and we're going to talk to you about how to do a better job. I think you all knew we were doing a horrible job. We talked about that earlier. One thing we're doing around this, we've got a thing called the Lone Star Depression Challenge. What we're going to try to do under the Lone Star Depression Challenge is over the next 5 years help 10 million Texans get their care in health systems that are organized more like the left side of that diagram I showed you earlier than the right side. And why is that important? It is important. Actually, I want to go to a different slide to explain why it's important. How do I get to the slide I want to show you? There, I want to show you that slide. It's important because if you take the 1.5 million people in Texas who have depression every year, these are adults, we only detect currently about 47% of them. That means we don't even notice if you have depression. We don't know. So you suffer and languish until you come to the attention of a police officer or somebody else, somebody maybe with suicide. But the ones we do detect, only about half of those people do we link to treatment. Because what we do is we hand you a list of numbers and we say, good luck finding a therapist. And anybody who's tried to find a therapist knows you're going to probably call 12 people, 3 of them are going to be dead, 4 of them are not going to be living in the state anymore, and 5 of them are going to have practices full until you get to one that is actually in your network. And so by the time you get to treatment, we're down to 1/4 of people. Then do they get good treatment? Remember what I told you earlier about measuring symptoms and giving people care? If you go to a non-physician for your care for depression and they never link you to any type of prescriber, you're not getting state-of-the-art treatment. State-of-the-art treatment includes consideration of medication. If you're in a therapist and saying we don't need to worry about that medication, you should worry about that therapist. And I'm not the kind of therapist that gives medication, I'm a psychologist. Also, if you're seeing a psychiatrist or a physician that says all you need to do is take medication, you should not see them either, because the best treatment includes a change in lifestyle, some cognitive behavioral interventions, and some treatment for your depression, all of which, by the way, can be delivered in primary care, which I'm going to come to here in a sec. So of the people who get care, only about 1/3 get treatment that works, and guess what happens for them? 2/3 of them get better. Do you know why? Because that's our success rate for treatment. If you get the right treatment, 2/3 of people from depression are going to get better. Just under 50% are going to have full remission of symptoms. They may have to take medication the rest of their lives, just like, by the way, people with diabetes do, but they're going to have full remission of their symptoms, full functioning, and another 1/3 are going to have substantial improvement, over a 50% reduction in their symptoms, which is going to make them much more likely to be productive at work, much less likely to die from suicide. So this is our problem, y'all. We got to go from 6% to 2/3. And how do you do that? You do it through detection and by giving people treatment quickly, as opposed to making them go find a therapist who isn't actually there. So now I'm going to go back to the slides where I was. Okay, how are we doing that? So a big part of how we're doing that is we're partnering with the business community. The most flexible insurers in this country are the folks who work for self-insured, the TPAs for self-insured organizations. So Dallas-Fort Worth Business Group on Health, the Houston Business Coalition on Health, as well as 7 other business groups around the country. We're working with the HR Policy Institute, which represents the chief human resource officers for about 200 of the Fortune 500 companies, and the National Alliance of Healthcare Purchasing Coalitions, which works with these business groups on health to basically work with them on these economics, because I know that Dr. Webster would love to give you some of these benefits in his health insurance, but he can't do that. He can't go to you and say, oh, by the way, I'd like you to spend 10% more, 5% more. He needs the purchasers, many of whom work with you all, to say, we need you to purchase things and do things in a different way, and we need you to help incentivize and change some things around, which I'm going to tell you what those things are. But that's what we're working on, and that's been really helpful. And we're in the first year of this initiative, but we're already gaining a lot of good traction and buy-in with most of the major insurers in the company who don't necessarily like that we're doing this because it's kind of a hassle for them. But they like being involved. And if you would like to talk to me later about this, I'm not going to tell you what the details are, but we would love to have your organization if you want to do this. We actually have an RFI language you can use when you're doing your purchasing that could at least get you information so you can make better decisions about which of the potential vendors out there are going to give your employees actual care and which of them are not. Which, by the way, you'll notice I'm not talking about workplace mental health awareness strategies. Not because I don't believe in them, I do. And you heard about some of them before, and we actually have some we work on. But I'm not talking about that because guess what is a really cruel thing to do? To get your employees all ginned up about getting care for their mental health conditions and then giving them the benefits you currently have. Because your benefits, I guarantee you, do not have very good networks and are not going to be very helpful to them. Now, should you still send them your benefits? You should. But you need to get your benefits better. And by the way, EAPs are not medical care. EAPs are for stress and to help people get through hard things in life. How many are people who have cancer do you say, well, go to see your EAP? I'm sure they'll help you figure that out. Probably zero. Now, if you have somebody with cancer who's moving or who's having a divorce, you might send them to an EAP because they can help with stress. I love EAPs, they're great, but they're not medical providers. And this is the only health condition that y'all put behind an EAP boundary instead of behind a medical boundary, which is the primary care folks. And by y'all, I mean we all do this. It's not your fault, but your companies are doing this. So this is what we're doing with this Lone Star Depression Challenge. Is we're basically taking 3 initiatives. One of them is this employer initiative to kind of get people's attention. The second one is working with health systems. Right now we're working with Baylor Scott & White and Dallas Methodist to basically implement this thing called collaborative care. What collaborative care does is it measures symptoms in every single primary care visit. So you can get detection just like they do for heart disease, just like they do for hypertension. And then you have somebody in the office who actually helps make sure you get that care. And every major insurance company currently pays for this today. This is a covered benefit. Medicare pays for it. We even got Texas Medicaid to cover it. And you know if Texas Medicaid covers it, it is like baseline mental care. So, but the problem is nobody's doing it. And so we're using this grant to basically do startup with 30 of our largest health systems, and we're going to be able to reach 2 million Texans just through Baylor Scott & White. And by the way, if you want to look at a health system that has a major commitment to doing this, Baylor Scott & White has made that commitment. And there's somebody you should put on your list. Dallas Methodist is also looking at doing this. They're not quite as far downstream, but they're working on it. There's going to be, Children's Health is working on this. We're going to have other health systems stepping up, doing their thing. You just saw Parkland talking about their initiative last week in the Dallas Morning News. This is the direction things are going. And if we do nothing, this is what care is going to be like in 20 years, but we're going to lose about 1 million Americans between now and then. We need to do this sooner. We know how to do it, and it's hard that we're not actually doing it yet. So I want to talk to you about the economics of this. So Frank showed you some of these numbers earlier today, and his were probably much easier to read than mine, but just look at the orange part versus the black part. The orange part is how much more things cost if you have a mental health condition than if you don't. So we're looking at rates of cost anywhere from 250% higher to 340% higher for comorbid health conditions. And so why is this, you say? Well, if you know anybody that has depression, or if you have depression, and probably about 22% of us, based on the national statistics, are currently suffering from some level of depression today, 3 times the baseline average, you know that it's a lot harder to do things. It's a lot harder to take care of yourself. It's a lot harder to eat well. It's a lot harder to get out of bed. It's a lot harder to go to work. So is it any wonder that if you have depression, you're going to have worse healthcare outcomes? So that's why it's so important, and why we can get numbers like this, 6-to-1 returns in real world implementations of the cost of putting that behavioral health care manager in primary care than waiting until people get to the hospital, waiting until people die from diabetes-related conditions, heart disease-related conditions, and you get much better care, and that's what it looks like right there. The patient has, rather than just the medical provider, they have a behavioral health care manager, just like you have a nurse. I don't think that my doctor would do a very good job of monitoring my cholesterol levels if that nurse didn't come and get me hooked up with a phlebotomist who takes my blood and looks at that. And people tell me, I was talking actually before dinner about, well, we don't really know how to diagnose mental health conditions. We do. The PHQ-9, which consists of 2 questions that if you answer them both no, we don't have to ask you any other questions. And if you answer them with an elevated version of yes, we ask you 7 more questions. We know with 80 to 90% reliability that you have depression. And why don't we catch the others? Because they lie. People lie. Now, when you say, well, who would lie when they go to the doctor? Think, do you eat the same food the week before you take your cholesterol test that you do the other weeks? Because I tell you, I do not. Those terrible people still catch me because it can't change apparently in a 24-hour period. But we know how to find your depression, and people lie for good reasons. They lie because they're police officers and they don't want to have to lose their jobs. They're pilots, they don't want to lose their jobs. I'm not saying that's a good idea. I'm just saying they've got good reasons for doing this. And so we're trying to get better, but we have this thing I call the bodily fluid bias in healthcare, that if we don't have a bodily fluid to measure, like a swab in your nose or like spit or whatever other bodily fluid, in my case blood, we don't think it's real. Well, it actually works pretty well, and y'all know math, so that's why I like hanging out here tonight. 80 to 90% reliability is way more reliable than my cholesterol is. They still don't know if I'm going to have heart disease. In fact, when I first took my blood test for heart disease, my doctor said, I asked my doctor, what are the chances I'm going to have a heart attack, given that I have these elevated levels? He says, about 50%. I said, why didn't you flip a coin? right? I mean, could have flipped a coin. I mean, we would have known 50%. I mean, it's not that helpful to narrow things down. We could do 80 to 90% by being able to have these types of tests out there. So we're pretty excited about it. So this is what the system will look like when we get things organized. You'll go to your doctor, and 80% of you who have depression will never see a specialist other than maybe the consultant psychiatrist who consults to the practice, because you don't need to. We get those 65% outcomes in primary care practices with just the behavioral health care manager doing the basic things they need to do that are non-biological, making sure the doctor gives you the right medication and consults with the psychiatrist. By the way, this also has really good outcomes for anxiety and also has really good outcomes for substance use disorder, has really good outcomes for opioid use disorders. We modeled this, and if we just had universal access to this, we could cut deaths from suicide by 1/3. We could almost eliminate deaths from opioids, because opioids are almost always treatable. The problem is there's so much stigma and barriers and difficulties getting treatment for them. We're really good at getting people hooked on them. We're not very good at getting the people the treatment that almost all the time, when you get access to it, works to get you off of them. So that's what we're trying to do. And this is the thing, it's not that different from anywhere else. We don't need to build more hospitals. We do for other reasons. We don't need to totally have a total workforce where we can all get to a psychologist. How many people go to an endocrinologist who have diabetes? Very few. And we need to save our psychologists and our social workers and our hospitals and everybody else for the more severe cases. And so you can do a great job getting your benefits done by talking to the people who buy your benefits and getting them to think about these things, to look for health systems, to look for networks that think about it this way, as opposed to coming and telling you that they're going to sell you some fancy new thing through the EAP, or they're going to come up with this really cool way to get you a few more social workers in your network. Those are all good things to do, but you have to make this transition to primary care, or we're not going to get ahead of this, because that's what we've done for every other disease. So that's us, and I'm actually going to go back to this diagram because this is what I want to stick on. Now, I want to say I've mostly focused today on systemic things that I want you to be aware of and to think about as you're within your company thinking about how to purchase the best healthcare benefits and mental health care benefits for your employees and their families. I didn't talk about what do you do about individuals, and I'm happy to do that, but I thought what I would do is, rather than get off into other topics, I'd just give you the core message and then we could answer your questions. So this is where I'm going to stop, and I'm going to answer your questions. And if you have a question, I'll repeat it for everybody else, but just shout as loud as you can. So yes, sir.
What percent do you think were the primary care physicians?
So what percent of primary care folks today can do that, or what could do that if they had the right supports? Could be able to care for somebody? Okay. Okay, so the question is, what percent of primary care physicians could actually do this? So one thing that is sort of a not well-known thing is most mental health care today is delivered by primary care. Over 50% happens there. And it happens very quickly in that 20 to 30 minutes they have, where you probably don't bring it up until the end of the session, and then they're like, dang it. All right, well, let me give you this medication, which I'm pretty sure works. So 50% of the care is happening there right now, but those outcomes I showed you are the ones, what the outcomes are. It's not working very well because they're not screening, they're not finding it until it's too late, right? Not too late, but until it's so much more complicated. I mean, imagine waiting 8 to 10 years for another disease, right? Things are so much worse. I mean, if you're depressed for 8 to 10 years, think of the toll it takes on your social network. Think of all the things at work that you missed, all the opportunities, all the things that now you don't have in your life to sort of be something to fall back on. And so what we first need to do is have those primary care docs detect it early. And so if they detect it early, it'll work better. Now, they don't want to do that. They don't want to just do the detection because they're like, I have more people I can care for already. Why would I want to screen for more? In fact, I was at a meeting at the Pew Charitable Trust 3 years ago, and the National College of Emergency Room Physicians was there. And we were talking about the value, because Parkland, by the way, is the only hospital in the country, a hospital system, that actively screens for suicide across all of their health systems, all of their services, which is fantastic. They've saved hundreds of people's lives in the OBGYN area or in cardiology, screening for suicide. Universal screening. We find it out, and most people are not going to hurt themselves. They're just thinking about it. But that group that is going to hurt themselves, they want to find them, and Parkland's committed to that. But the American College of Emergency Room Physicians said, we don't support that. And we're like, why? Well, we have too many people to treat already. So I wanted to jump across the room and hit him. But because what other condition would we do that for? Like pancreatic cancer, right? You don't want pancreatic cancer. Like we don't do a good job saving most people from pancreatic cancer, but we certainly try. Like just because 95% of whatever the percentages of folks are gonna die, doesn't mean we're not gonna try. So we have to try to make that shift. So what collaborative care does is it gives the doctor somebody to help them. It basically gives them somebody to function like the nurse. So why does your blood pressure get taken and why does your temperature get taken? Because the nurse does it. The nurse helps the doctor. So by having the behavioral health person in there, they do all that sort of screening and stuff. They track you, and you're probably not going to come to all your appointments if you're depressed, so they track you down and they make sure that you follow through on your prescriptions. And then if things aren't going well, they notice because they're repeating these measures. They keep measuring your symptoms, and when you don't get better, so we're just basically doing it less bad, and we get pretty good outcomes. Does that make sense? Yeah. I mean, really, that's true. I mean, that's how a lot of medical innovations have gone forward. We just started doing things more systematically and doing them less bad. We used to lose 100,000 people a year to medical mistakes in the health systems. Now we have all these QI systems that have gotten that down dramatically. Sherry or Frank probably know how low it is, but it's down dramatically just by not giving people the wrong meds accidentally. Not, all these ways of avoiding things. That's basically what this does. We also have this really exciting project right now with Children's Health where we're trying to figure out in a pediatric setting how to do that better, because half of these disorders begin by the time you're 14. So it's also really important that pediatricians and UT Southwestern and their training program is looking at this. So 20 years from now, this is going to be a lot better, but we're just trying to make it happen sooner than we otherwise would. Does that answer your question? Okay, cool. Was there another question over there? Any question? Okay. Yes, sir. And then we'll come back here.
First of all, thank you for your excellent work in this area. One of the challenges I think that we sometimes have for this whole topic is we like to pigeonhole mental health to a box, right? We want to compartmentalize it and say this is traditional health, this is a convenient place to kind of house it. But I saw the slide you had about funding, and I saw another slide a few weeks ago that showed funding to psychiatric hospitals since 1980 through present, and basically there are none. And the funding for psychiatric hospitals has essentially evaporated. My son and I were downtown Dallas today at the hospital, and we were approached by 3 people that I felt terrible about them. And it got me to thinking about how should we be thinking? If I can ask you to zoom out.
Yep.
How should we be thinking about the cost and impact on society here in DFW of mental health and the issues that mental health impacts could be wide, right? Especially young people.
Yep.
But I'm just wondering if we were able to reframe this in a broader context, if it would perhaps help us with mobilizing more effective options.
Yeah, it's a great question. Did you all hear that over there? Okay, I'm going to repeat that because it's a really good point. So we have far fewer psychiatric hospitals today than we used to have. We've really narrowed that down. We've got a pretty high percentage of people who are homeless have mental illness. We have people in our jails who have mental illness. We don't have safe places for people to go when they're in that sort of acute state. And there's a lot of things that happen that are bad because of that. And so if we zoom out and kind of look at that bigger picture, kind of how does that fit into the stuff I was saying? Is that a fair? Yeah, okay. Did you hear that? Okay, good. Okay, good, you're welcome. Good question. So I didn't focus on that as much tonight because that's not really in y'all's wheelhouse at work. At work, you aren't dealing with homelessness as much. You are dealing with some people with acute needs. I really wanted to focus on how do we get ahead of this disease. But you're 100% right. And that's why we're really psyched. Can I say psyched? I can, I'm a psychologist. We're really psyched that the legislature just approved full funding for UT Southwestern to build a 250-bed state-of-the-art psychiatric hospital here in Dallas that is not going to have people have to drive out to Terrell to that. I mean, people at Terrell are great, but that facility was condemned and is eventually going to have to be razed to the ground. So we're going to have, and that facility is going to be part of the Clements Hospital system. It's going to look just like the other hospitals because these are medical conditions. So it's super exciting that we're going to do that. And I'm going to tell you about the reason why that's so important. But one thing, actually, I'll tell you about that right now, then I'll go back to the other point. That's so important because we do have people in what I like to call stage 4. I mean, there are a lot of folks we didn't get to sooner. There's a lot of folks who we need to help, and these are folks who are most at risk. And by the way, when you are suicidal and you really are going to hurt yourself, you do need to go to a hospital a lot of the times. We do need to keep you safe. If you have a psychosis and you're going to hurt someone else, you're going to hurt yourself, or you're just totally confused, we do need to get you to a hospital. And so having more resources, and also having resources here as opposed to 100 and whatever miles out in the non-urban areas of the state, is a much more contemporary way to work on this. So we do need to have those resources, and it's really good. But we also need to recognize what is a mental illness versus not. Most homeless people do not have mental illness. I mean, and by mental illness, I mean severe, protracted mental illness that is the primary reason why they are homeless. Most people are homeless because of financial issues, because this is a really expensive place to own a house. It's not an accident that the places where homelessness is the highest are the most expensive cities in the country to live in. And so a lot of what several foundations are doing in partnership with the city right now to address affordable housing and deeply affordable housing for people in poverty are fantastic solutions. So one thing we need to be clear about is that homelessness is not primarily driven by mental illness. But if you have a severe mental illness and you're homeless, then you're in a really bad spot. And so there's about 20% of people who are chronically homeless, and about half of those folks have mental illnesses. So about 1 in 10 people who are homeless have mental illness. The other people are using substances, and have very severe mental illness. Now, you may be depressed, you may be anxious, but I'm talking about the severe debilitating mental illness. So I think it's really important that we think about these things soberly. We think about separating them out. And I think there's a couple things that make it hard for us to do that. One is that we all know what it's like to be sad. We all know what it's like to be worried. And we tend to generalize from that and think that therefore we all have some idea into what mental illness is. And we don't. Mental illness is not the same as being worried or sad, but it looks the same. And so I think a lot of times there's this sort of mistake around that. Also on the other side, and this probably affects you all more, I'm guessing just based on your questions, is we also care deeply. So when somebody tells us they're suicidal, it's way more upsetting than if somebody tells us they have cancer. I mean, people, in polls, they say, would you want your child to have mental illness or would you want your child to have cancer? People answer cancer all the time because they don't want their child's brain to be affected. So we're kind of scared, we're upset, we don't know what to do. And that causes us to not really use the same sort of thinking that we use for other illnesses. And also, we in the profession did a bad job helping you. Remember what I said we were doing back when I started? So we're doing a much better job now measuring these symptoms. And what I've asked people to do is to take what I call the 30-day brain challenge. 30-day brain challenge is for 30 days, pretend like your brain is a part of your body. And see what changes. Because people exercise, diet, all these other things, for the vast majority of people, we don't tend to think that that's what's affecting our mood. We think, well, we're upset about something. No, you probably just didn't eat. Or maybe we are upset about something. And so I think that whole integrative thing is something we have to break the things down. So whether it's from being able to be more sort of distant from it, be more hopeful about it. And I think the last thing is getting information that these really are treatable disorders. I mean, we used to have huge stigma around cancer, right? Because we didn't think you could treat it. So when Betty Ford came out and said she had breast cancer, that was a big thing because it was like sharing with somebody that you had a death sentence. Now it's much more helpful because we know we can get you the care you need and we've got a really good chance of helping you. And we have similar numbers for mental illness. We just need to get them out there for people to be aware of. And then we need to deploy them better. So I don't know. I mean, those are various thoughts. I don't know. There may be other things. There certainly are, I think, ways to get involved in the community to kind of take a more proactive stance on these things. But those are some of them. Were there other ones you wanted to address, or are those kind of the main ones? Well, I just want to make sure I answer your question. Yeah, I think, gentlemen, yes, sir.
So, from a practical standpoint,
I'll repeat it. No, there's no way they're going to hear. It's too big a room. I'm going to have to repeat it anyway. You could try.
So I'm about to renew my health insurance.
Yeah.
I'm talking to a handful of, or less of major health insurers. What do I do differently to do what you just said?
Okay, so question was, when this gentleman's up for putting out for bid their health benefits, what can he do differently to make sure that he gets people who could do more of what I'm talking about than other folks? And what could you all do? Is that fair paraphrase the question? Okay, so first of all, are you all self-insured? So you're gonna have to go out into the open market and get a group policy, large group policy? You can't. Yeah, okay, so if you're in the smaller large group policy, there's not much you can do. Because these benefits are designed, all of them are basically the same. You can say, is Baylor Scott and White in our network? Because Baylor Scott and White is starting to do this. Now, they're only doing it in 5 of their 175 clinics, but they're trying to do it in all their clinics, and within 2 years, all their clinics are gonna have it in there. You can ask those kinds of questions, but you're kind of in a difficult spot on that. If you're self-insured and you have, your third-party administrator, there's a set of data analysis that we have in this RFI that you can add into your vetting process, where you can ask them to respond to talk about for example, what does their network look like? How many out-of-network claims do they have for psychiatry versus cardiology? How much higher is that? And we know nationally from working with Milliman in 2019 that it's about 5 times higher. So the out-of-network rates. So we have that, and I'm happy. You can get me at the mmhpi.org. We're happy to link you in. Dallas-Fort Worth Business Group on Health can also get you this. And right now, what we're offering for a limited time only, through this Lone Star Depression Challenge, we would love to work with 4 or 5 businesses to actually help you analyze your data on that and have our folks work with you. Not because we want to talk you into anything, we just want you to see what's happening, and we want to learn from you too. Because we know in aggregate what's happening when we have these large samples. We don't know, though, the pathway within your organization to do a better job with that. Yeah, exactly. Yeah, so we're hoping we'll get, and Frank and I are actually talking at the business group on health in December, and we're hoping we're going to get 4 or 5 organizations that are going to want to work with us on this and share the information. And then they'll help the rest of us. I mean, if they're willing to do that, that's the kind of thing that's eventually going to tip the market. But they got to have a place to purchase it, right? They've got those codes on, but if no one's actually providing this care. So that's the other thing. If you all are on boards of health systems or you got friends that are, tell them that they really need to think about doing these types of shifts, and tell them we have resources to help. Yeah, so she's asking if we're working with, he's asking, I'm gonna repeat it, don't worry. He's asking if we're working with any of the major brokers who are on these things, and we're working with the major benefit consulting firms, and we're basically trying to get them to think about this, and we're getting good traction. It's a little early to say which ones are best. I mean, it's a different way of thinking because they're so used to selling y'all EAPs, which I like EAPs, but EAPs are not medical care. So that might be another thing to just, well, no, you can't really, anyway, yeah. Yes, sir.
People that buy healthcare off the exchanges, how are they covered in terms of these mental health, behavioral health topics?
Great question. So basically, it's like a version of the small group market, so not great. I mean, basically no better than my folks are. So I only have 100 employees, so we don't have as many options as other folks do. It's covered, and that's a start. I mean, we want to have mental health benefits covered, but like Medicare and Medicaid are some of the worst benefits because they're actually, parity is not being enforced with those organizations, and Medicare's benefit is really limited. So not great. And so this is the kind of thing that we're trying to work on. And one thing that kind of gives us hope is there haven't been a whole lot of other medical innovations that have been started in the Medicare area or in the Medicaid program. I mean, most innovations come from our research institutions, our commercially insured populations. So what we're trying to do is to push that more, because actually mental health has been much more relegated into the public sector, which is fine. Like, I mean, we need good health care there as well, but we need to have it in the private sector as well. So that's why y'all are in such an important position to kind of raise awareness of this as y'all are looking at benefits. Probably one more question, because I think I need to make sure you're out here at 8 or I'll never be invited again. So yes, sir.
So we're sitting here in the middle of Texas,
Yeah.
and we're supposed to be independent and tough.
Yeah.
And traditionally, there's been a stigma that having mental health issues is perceived as weak by society, by your peers. I know you're speaking to a lot of really smart financial executives, rational folks, but we're not really representative of the population of Texas as a whole. What can we do as a society to get the word out? So I think you said 1.8 million people, less than half, actually seek treatment. That to overcome that stigma about mental health. I know recently athletes have come out and other people. How can we, strong, tough Texans, you can still be strong and tough and independent and still seek treatment for an issue that can enhance your life and maybe lengthen your life?
Yeah, great question. So should I repeat that? I'm gonna repeat that. So question is, what can we do as strong, tough Texans to get the message out there that you should still get mental health care, that we can be strong and tough, and we'll actually be more strong and tough, right, if we actually take care of ourselves and get the kind of mental health care and kind of overcome the stigma that we have around seeking mental health services. First of all, our kids don't have as much of this as we do. When we do these polls, we do surveys, my grandparents, my grandma alive? No, she's not. If my grandma was alive still, she would have a lot of stigma around this. My parents have a fair amount, I have less, my kids have less, and then these young kids coming up have very little. So that's one thing, waiting will help. But what can we do now about it? One thing is we can remember that stigma isn't just about mental health. And I mean, let me just say to the guys in the room, do any of you like telling people you're sick? For any illness? I mean, you like telling people you got a cold? You like wearing the mask? I mean, guys are terrible at wearing masks. I was taking a survey yesterday in the airport. Men are way worse at wearing these masks than women are. I mean, they got them on their chin, they got them on their head. I mean, it's at least, I mean, okay, you don't believe in it, but wear it because you're give me a heart attack because I got to wear it. Anyway, so men don't like seeking care in general. So I think that's important to point out because we need to normalize that. Because we pretend mental illness is the only illness we don't want to get treatment for. No, nobody wants to get treatment for illness. And getting treatment for illness isn't fun. I don't like doing the cholesterol stuff. So by normalizing that, I think we make some bridges because we don't sort of, we say mental health that we put on this pedestal that's so much worse than everything else. And then, like I said at the beginning, treat it like any other illness. Watch for your friends, because your friends are going to share this with you. I mean, if you show you're open to talking about your mental health and your own health care, self-care, people are going to talk to you about this. So first of all, be open about it. So I have an anxiety disorder. I've had an anxiety disorder since I was a kid. I mean, it's in my baby book. I think when I was 4, I said, "Mom, I'm so anxious," which was very impressed that I knew the word anxious. But I didn't get treatment for that. I didn't get treatment for that until I was 26. And so, I don't know what to say. I don't know what to say. We tell people we don't know what to do. I don't know what to do. Yeah, you do. Take them to the doctor. Say, let's go to your doctor. Go with them. And then say, by the way, when you go to your doctor, they might not be that helpful because I saw this guy at this dinner the other night that said, actually, most of them aren't helpful. But if you want to make them be helpful, be persistent. Go with them. Help them. If you're persistent, if you're that care manager, the only thing that makes it work better is somebody's there to get them there to the appointment, to bug the doctor, to say, doctor, this doesn't seem like it's working. Did you do a symptom measure recently? Because I don't remember you doing that. Oh, I guess I should do one. Yeah, why don't you do one? And so doing that kind of advocacy, which by the way, you got to do for back care. I mean, when my wife hurt her back, it was hard to find a back doctor, and they all want to do something different. So advocating for your loved ones when they have a health concern, encouraging your friends to take care of themselves, using yourself as a role model, that's what we do for any health condition. So just do the same thing you would do if your friend said, I have super high cholesterol and I think I'm worried I'm going to die of a heart attack one day. Say, well, maybe you should eat differently. Maybe you should take care of yourself. Maybe you should go to the doctor. Those are the kind of things that are going to help them. And if that doctor doesn't work, get them to a different doctor because there are good doctors out there and you may need to help them. But those are the things I think, when I think about it, does that kind of make sense? Yeah. Okay, cool. Jim? Oh, good. I think so. I think it's 8 o'clock, so I think I'm supposed to do this.
Seemed like a good stopping
Okay.
point.
Yes, sir.
Seemed like a good stopping point. So, Andy, thank you so much. Tom, Tom. Thank you, Andy. Great topic, very interesting. We really appreciate it. We will take your guidance to heart. And that wasn't like a cholesterol joke. I truly will take it. I just came to me. Thanks everyone for being here this evening. Remember to turn in your CPE cards when you're on the way out. Our next chapter-wide event is the Technology Breakfast on December 7th. Our next chapter meeting will not be till January 10th. So no chapter meeting in December. There are lots of SIGs coming up. Check the calendar, be there, network, and we look forward to seeing you at an event in the very near future. Thanks, everybody.
Oh, thanks. It's fun to talk about. Yes, thank you.